Dialogue with a Doctor, featuring Southwest Florida's leading physicians.
Welcome to Dialogue with a Doctor. We're here this evening speaking with Dr. Raymond Phillips, practicing gastroenterologist in Naples. This is a show where we talk to many physicians and get information from them, educational information that they want to convey to the public. And tonight we're going to be speaking about inflammatory bowel disease. Crohn's disease and ulcerative colitis are the two types of inflammatory bowel disease. But first we want to introduce Dr. Phillips and want to know some background about you, where you came from.
Sure, Greg. Well, thanks for having me back. I appreciate it. It's always fun to come and talk to you and again have an opportunity to delve in certain topics more deeply. I'm a gastroenterologist. I'm a specialist in gastroenterology, and what that entails is an individual who's gone to college. I went to Princeton University on an Army ROTC scholarship. After graduating from Princeton, I went to medical school at Washington University in St. Louis, and then I did my internal medicine training at Jefferson Hospital in Philadelphia, and I was chief resident there. Then I came on active duty and was assigned for 2 years at Fort Leonard Wood in Missouri. And then I was selected to do gastroenterology training at Walter Reed. And then after 2 years, I was assistant professor of medicine at Walter Reed, doing research and doing clinical research there. And after I completed my obligation to the Army, I came down to Naples in the early 90s. And since then, our practice has gradually grown. I work with Dr. Susan Lebersky, Dr. Michael Marks, Dr. Gustavo Rivera, and our practice has gradually grown over these years to the extent that now not only do we have an office in Naples, but also an office in Bonita Springs and as well as Marco Island. But in addition to adding additional physicians and accumulating additional physicians, the practice itself has grown, and we've done a number of different, pursued a number of different educational activities, and among them clinical research, which involves principally now inflammatory bowel disease, Crohn's disease and ulcerative colitis. And also we're making outreaches to the community in an effort to try to provide educational opportunities. In the context of inflammatory bowel disease, this show is certainly an opportunity to discuss in detail the issues in terms of how and why and how to treat it. But also, we've established a support group for inflammatory bowel disease. We meet every Thursday, not every Thursday, but the first Thursday of each month in the Naples Central Avenue Library. And my office can give you details on that, but it's 5 p.m. the first Thursday of each month. And then we've supported other activities such as this year, November 1st, we have the annual Take Steps awareness campaign that's put on by the Crohn's Colitis Foundation. But for Southwest Florida, we're holding it this year in Estero on November 1st. So certainly you're welcome to come on out, Greg. But today I wanted to talk about issues, as I said, to dive into the pool in terms of knowledge and related to inflammatory bowel disease with regard to Crohn's disease and ulcerative colitis, to talk about how does it occur, why does it occur, what we can do in terms of treating with regard to diet and activity, and in particular medications that we now have available to us. And Crohn's disease, we talked about this before, and there's a historical perspective about this. And it came into the sort of recognition by the American public in the 1950s when President Eisenhower was diagnosed with Crohn's disease midway through his second term in the presidency. He was hospitalized at Walter Reed. In fact, he was dying from Crohn's disease. He had obstruction of his GI tract, and there was no therapy at the time. And it finally was resolved that he should be operated on. He was operated on. There was a little controversy there at the time. The gastroenterologist was recommending newer surgery, and the general surgeon at the time was saying, well, I'm going to do the operation I've been trained to do. Fortunately, the general surgeon was successful in doing his conventional operation. It's not the the one that's done nowadays, but it was successful for the president. He recovered. General surgeon, the surgeon went on to become Surgeon General of the United States. The gastroenterologist who argued for another operation, he went out to Alaska. So Alaska in the 1950s wasn't a welcoming place. But at any rate, it's nothing wrong with being lucky. But now we have a notion that you have a better notions in terms of treating this, and we're more effective in terms of treating this in a timely way before it comes necessarily to an operation. And the treatment had very much been one of using steroids, and steroids are, we've discovered, developed in the 1950s. They're useful for controlling initial symptoms, but not for maintaining or curing. And then other medications that came available, drugs collectively called mesalamine, but they're individually, their brand names are Azicol, Lialda, Dipentum, Colazol. These are all variations of the same thing. And for many, many years, we had really no effective therapy other than these things until we realized how the immune system was responsible for provoking or causing inflammatory bowel disease, because now we realize it's an interaction of your immune system and the gastrointestinal system responding to the microbiome, and we've discussed the concept of the microbiome before as being a bacterial population within the colon, but your immune system responding to the bacteria within your GI tract in an unusual and aberrant way, and leading to severe inflammation in different portions of the GI tract. Now, ulcerative colitis is inflammation of the colon. Crohn's disease is inflammation, can be anywhere throughout the GI tract, but also the colon. But so it's a response of your immune system, an abnormal response of your immune system to the bacteria within your colon, and presumably there's some interaction that's causing this stimulation to occur. And
so it's not your antibodies or your immune system. It's attacking the bacteria. It's not attacking the intestinal wall.
Well, you're exactly right. It is because the bacteria interface with the intestinal wall, and there is a mechanism where the normal barrier that separates the bacteria from the lining of the GI tract, it's a membrane that selectively allows some bacteria across, and by metering how the proteins from bacteria that can cross this membrane, the immune system then can react in a measured way and modulate itself so that it doesn't lead to a vigorous reaction. But what we're discovering is many individuals with inflammatory bowel disease have an alteration in that permeability, more bacteria, more protein, and are able to traverse that membrane, leads to a more vigorous immune response, and that immune response is directed at that interface on the wall of the intestine, leading to inflammation. And so that inflammation on the surface of the intestine leads to ulcers, scarring, that can lead to blockage.
So it's just a battle being fought in an inconvenient place.
Yes, indeed. Yeah, so you get all this collateral damage, so you have to extend your metaphor there. So you lead to all this collateral damage that over time, with the accumulation of scarring and Crohn's disease, can cause blockage and prompt an operation like President Eisenhower, or alternatively, it can lead to such severe inflammation of the surface that it can lead to fluid loss, bleeding, which is what you frequently will see in Crohn's disease as well as ulcerative colitis. So now that we had an understanding how the immune system is involved, we began to use medications to try to calm down the immune system. We call them immunomodulators. And these initial immunomodulators, methotrexate, 6-mercaptopurine, azathioprine, they were formerly chemotherapeutic agents, but in small doses could modulate the immune system. Now, with with the amount of research that has been done over these last 25 years, we have a much, much clearer understanding of how the immune system leads to inflammation, how very specific messages are released and sent to white blood cells to stimulate them to be active. And by understanding these messages that are being transmitted, the pharmaceutical companies now have been able to develop, now that they have a target, develop particular molecules that can block those targets and lead to a reduction in inflammation. And the prototype of this, one of the first drugs that became available was one called Remicade. And because it interfered with these biological steps, they're collectively called biologics. But Remicade was the first. Humira followed. There was in that same category, they're called anti-tumor necrosis factor antibodies. But what they do is block a specific message from the immune system and block its effect on white blood cells and prevents the white blood cells from being activated and leading to more inflammation. Now, there's more though. There's more. And so these different mechanisms have been discovered, and now as we discover these different mechanisms, other drugs are being developed. And now we're able to more consistently get control of inflammation. Inflammation to the extent that now we can actually eliminate inflammation completely and reestablish a normal mucosa, a normal lining to the GI tract. And so many people are going into this entity called a deep remission, where they're completely asymptomatic. And now we're finding that if we can implement therapy early for severe Crohn's or ulcerative colitis, we can prevent surgery and the complications of these diseases. And so we're seeing a decrease in surgery rates and hospitalizations as a result of using these new medications.
So that's my sister got a bout of this for the first time. So she wanted to get off her medicine as soon as possible, but her physician was telling her, no, you need to stay on it in the beginning. Is that what you mean? Get it controlled right away?
Well, exactly. In years past, we used to be happy, oh, you're feeling better, that's grand. Mm-hmm. But what we learned is that you can feel better, but there can still be a lot of activity, inflammation occurring within the gastrointestinal system. With these newer medications, not only can we make people feel well, but we can actually completely eliminate the inflammation within the GI tract, and as a result of that, the chance of a relapse becomes much, much less, and there's not accumulation of more damage within the colon or the gastrointestinal system.
You continue the drug indefinitely?
Well, that's a difficult circumstance, because after 2 years or 3 years or 4 years, if someone has been asymptomatic, the inevitable question comes up, gee, do we still need to use this medication? Now, what we're learning is individuals who had severe disease at the onset, if you stop the medication after 2 years, there's about a 50% or 60% chance they'll relapse within the first year. But we're also learning that, well, perhaps if we continue to use the medication, maybe we don't have to use quite as much. And so now we have the technology to actually measure the medication in your system. And by making certain there's enough of the medication in your system, sometimes we can get by with far less medication, which is, of course, less expensive. And so that's one of the emerging strategies, is trying to tailor the medication to the individual and give them what they need, but more than they have to. But there is studies right now looking precisely what you're saying, of withdrawing the medications and seeing if we can identify individuals in whom that would be a more favorable likely result. That is to say, they wouldn't have a relapse. So, as I said before, there's a number of different mechanisms involved in this inflammation. A newer addition is this drug called Entyvio, which was released last year. And that drug, which is a product of Takeda, is a drug that's effective for Crohn's and ulcerative colitis, and it works differently. Instead of blocking the signal from the immune system to stimulate white blood cells, this particular medication prevents the white blood cells from ever honing in on the area of inflammation. And let me elaborate on that.
Please.
It's the and this is just extraordinarily interesting, because the white blood cells that have been stimulated, you know, for example, I mentioned before, you have bacteria that make their way across the membrane and that stimulates the immune system, and that stimulates white blood cells. Well, those white blood cells, they go into the circulation when they're stimulated, but they always remember where the area of inflammation came from. They remembered where they came from, the gastrointestinal system. So the white blood cells that were stimulated in response to that original inflammation, they may circulate around the body, but they still know where the inflammation that stimulated them came from. And when they come back to the gastrointestinal system, as they approach the gastrointestinal system to the tiny little capillaries, there's little road signs that project into the capillary saying you're approaching the gastrointestinal system. And the little white blood cells have a matching code, that protein on the surface that says, well, I came from the gastrointestinal system. So they high-five each other going down this capillary, and each time these proteins interact, it slows the white blood cell down just a little bit, until it stops. And then it takes an off-ramp where it's squeezed, and then there's additional proteins that allow it to squeeze through the wall of the capillary, and then come back to the area where it was born, where it was originally stimulated, so it can reinforce more inflammation. These anti-homing molecules block that. And so the white blood cells can't go back to the area of inflammation. And so what happens is an area of inflammation gradually diminishes. Sort of like a riot. You get a bunch of people rioting in a place, and rioters being people, they get tired out. Oh, I want to go home, I want to take a break, I want to take, so they leave the riot scene to go get replenished. But if they're not allowed to come back, well, the riot gradually diminishes over time.
Well, we're going to take a short break before we come back to the rioting white blood cells.
Right, you are.
We'll be back in just a minute after a short break.
Thinking of buying a home located in a golf course community in the Naples, Marco, Bonita, or Estero, Florida? Here is what Mark Lai, former PGA winner, says about Realtor Michael York of the York Real Estate Group of Downing Fry Realty.
Hi, I'm Mark Lai. If you have any real estate needs in Naples, Florida, the one company to contact is the York Real Estate Group. Also, if you want a golf course property to invest in, Michael York of the York Real Estate Group is the guy to contact. Michael knows every golf course in Naples. I will tell you this, he's been in the golf business for a long time. He's played all the great golf courses down here, and he is an outstanding realtor. I've known him for quite some time, and he's he's got a lot of integrity, and he very much knows his stuff on all the different clubs here in Naples. So the York Real Estate Group is a great place to start. So if you have any time or anybody that wants to visit down here in Naples and look at the options out there, please contact the York Real Estate Group.
Well, we've been talking more about Crohn's disease while you've been gone, because we're science nerds at heart, but we want to convey this information to you. Welcome back to Dialogue with the Doctor. We're talking with Dr. Raymond Phillips, a gastroenterologist here in Naples, and a very smart one, about inflammatory bowel disease, Crohn's disease, ulcerative colitis, similar or same maybe. Where were we?
Well, we were just talking about how there's these different mechanisms, these drugs that are being developed called biologics that can interfere with biologic steps that relate to the immune system. The immune system, how it leads to inflammation in the gastrointestinal system. And we talked about one class of drugs, anti-tumor necrosis factor, and we were just talking about these anti-homing molecules, the prototype of which is Entyvio. And we're doing actually a study looking from this product from this company called Genentech that's looking at another anti-homing molecule that not only does what I've described before in terms of preventing activated white blood cells from finding their area of activation, but also it also prevents them from staying in an area of inflammation. So using that sort of that analogy of a riot, you know, when a policeman comes up there and says, move on, this particular blocking molecule prevents the white blood cells from remaining there and just sort of drifts away. So it can't stay there to provoke inflammation. And you see how the importance the white blood cells are to provoking inflammation. And so there are even other molecules now. One of the ones that are most exciting now are drugs that are being developed that are oral medications that, that can be taken that are seen to be effective in phase 2 trials for ulcerative colitis and Crohn's disease that cause a reduction in inflammation in the lining of the gastrointestinal system by interfering with the local immune system. So this is very exciting for us because now you have a way of influencing the immune system just within the gastrointestinal system and not affecting the immune system in the rest of the body, which is the reservation that a concern that many patients have. Hey, that immune system's there for some reason. It's just not hanging around. Well, yeah, it helps protect you from infections and monitors for cancer, et cetera. And so if it can be selectively influenced just in the gastrointestinal system, then it holds great promise, particularly if it's an oral medication. So that's why, you know, in this last 15 years, there's just been a tremendous proliferation of new products that are take advantage of this research that has been ongoing for these last 40 years. And now we're beginning to see the sort of the development of these products and implementation on a clinical basis. So it's a very, very exciting time to be able to use these medications and use them effectively. Because the people who affected this, you know, they're usually very young and very most productive part of their life, 20s, 30s, and 40s. And there's another group, an older group in the 50s, 60s, and 70s that are also affected. But it can profoundly affect their lives, prevent individuals from enjoying their lives, preventing them from being able to work and raise families. And so it's really exciting for us to have a means to be able to help them in this fashion. And it's a great example of how steady research over time has led to improvements that now you can see improvements in your everyday practice. But you know, talking about these things, they're difficult concepts, and as a result of these very detailed studies now that have been done, there's very detailed information about adverse events. And that's why when you see these products advertised on television, there's a whole list of side effects because they've been so well studied. You know, it's a difficult circumstance because individuals will use medications like steroids to control ulcerative colitis and Crohn's disease. And steroids have tremendous number of side effects. It affects every tissue in your body. But individuals have become so used to using a medication like that on a ready basis, and they're so familiar with it that they don't finally appreciate, you know, how serious the side effects are of those medications. Sort of goes back to that old saying, you know, familiarity breeds contempt. You know,
so the current standard for those patients that I see taking steroids and have been taking it for a long time, they can be transitioned to these medicines?
Yeah, that's what should be done. That's what should be done. Mm-hmm. And rather than taking a course of steroids 2 or 3 or 4 times a year, it only takes a month to get under control and I only have to use it 3 or 4 times. But each time you use it, it affects every tissue of your body. The way you feel, the way you think, you know, the way you taste, the way your skin, your muscle, your bones, your tendons. It affects everything. And it can cause side effects with regard to your immune system in terms of compromising your immune system as well.
Steroids are commonly used in the initial phase?
Typically, we're more and more using them as a stepping stone, to use them to get rapid control of the symptoms in the first few weeks or in the first month or so, and then using that as a transition to something else. It's not being used as we used in the past as repeated courses over the course of years and years.
Well, steroids have had such a bad name. I just wanted to make it clear that they do have some use.
Well, they're particularly important, and they were hailed as a miracle drug when they were developed in the 1950s. And of course, now we're talking about, steroids that are called corticosteroids, which have an anti-inflammatory effect. We're not talking about anabolic steroids that give you steroid rage and so forth. Those are steroids like testosterone that lead to production of increased muscle mass and so forth, but also can affect how you feel and how you think. But these are anti-inflammatory effects that we're looking at, and can have a profound effect. Point being is that we now have effective therapy. We can't quite say the cure word, but we have effective therapy that can put people in remission, and now have shown that we can actually prevent complications that lead to operations. And so now it's not an issue it's an issue of rapidly identifying an ill person and rapidly getting them transitioned to these medications to control their symptoms, rather than stretching out this process for months and months before you finally get control of their symptoms.
Are there any other commonalities in people that get inflammatory bowel disease besides age?
Well, what we're learning is that there are certain genes that are more common among individuals that have troubles with ulcerative colitis and Crohn's disease. Certain genes that relate particularly to the immune system, and that membrane that we're talking about. It's sometimes referred as a leaky gut, but it refers to this membrane and the proteins that make it up to separate the body from the lumen or the bacteria within the colon. But the commonality in terms of mechanisms of things that might be a common strain, there's some thought that bacteria in the population might lead to a more vigorous immune response if an individual is not exposed to certain germs when they're growing up. If little Johnny's not allowed to play in the sandbox and is kept particularly is not allowed to get any dirt in his mouth or eat any dirt and so forth, he might grow up and not be exposed to that many germs. And there is a thought, it's called the hygienic hypothesis, there may be more vigorous immune response when they finally do come in contact with certain bacteria. Now that's a common hypothesis associated with asthma as well as various allergic illnesses such as eczema. But it has some thought that it might be relevant to inflammatory bowel disease. So the point I'm making is, hey, there's lots more that we can do, and frequently, that involves working closely with your gastroenterologist, not only to get you feeling better, to put your disease in remission, and there's much we can do, but it involves seeking out a gastroenterologist who has the expertise in this, is willing to listen to the patient and to work with you in terms of getting you well.
Thank you for being with us at Dialogue with the Doctor, and we'd like to thank Dr. Raymond Phillips for being here as well. Thank you.
Thanks a lot.
And we want you to come back.
Oh, thanks so much.